Good morning, Jane. Good morning, Amanda. I'm Jerry Martin, the Clinical Engagement Lead for NHS 11 in the North West. Jane, you've been the Programme Director for NHS 11 in the North West. Welcome. And Amanda, you've been the Clinical Lead, and welcome to you. Just like to ask you a few questions and get some views on our experiences of the pilot in the North West. So perhaps starting with you, Amanda. What do you anticipate to be the change in general practice workload following the introduction of 111?
Well, this is one of the biggest concerns from GPs, that they would find themselves during the day with a lot of extra patients, and actually the evidence from the pilot in Lancashire shows that there's almost no impact on daytime workload in the GP surgeries. Patients may call 111 during the day, and some of them do. The numbers that are calling with an outcome to go to their GP within opening hours, it's coming out less than one per surgery per day, much less than that. And so it's not something that's caused any concerns for the GPs in the pilot area.
What information, Jane, will we receive in general practice regarding patient contacts with 111? And what's the expectation that practices will do with that information?
Well, NHS 111 will send information on any patient that is called 111 to general practice by 8 a.m. the next morning, similar to your out-of-hours procedures now. So you would receive that, see what the patient had done, needed doing, and that would be down to the practice what they actually did with that information. But going forward in the procurement, we have put in that any patient that has that calls 111 in the daytime and actually gets a disposition where they need to speak to or see a clinician on the same day, that information will come directly to the practice as it happens. So they will be forewarned about patients about to ring them to say they need to be seen. So that would be quite useful.
So the practice will be forewarned?
Absolutely.
Of any extra workload?
Yeah.
That's useful. Amanda, where are patients referred to another service, are they expected to comply with timescales indicated by 111?
Once a patient's contacted the 111 service and been through the NHS pathways process, the disposition, the outcome of that will give an indication of what the patient's needs are. So it might, for example, say you need to be seen by a primary care clinician within 4 hours. It's perfectly okay for the out-of-hours service or the other services that patients are referred to reassess that patient and to make changes in that timescale depending on the patient and the course of the condition.
So change in clinical circumstances can therefore be met in that way?
Change in clinical or patient circumstances, so we're not holding the clinicians in the out-of-hours service, for example, to the outcome of the pathways assessment if things have changed.
And you picked up there that the pilot uses NHS Pathways as an assessment tool, which is operated by non-clinically trained staff. Can we be sure this is effective in correctly assessing patients and identifying the most appropriate service for their needs?
Yes, many GPs are used to clinicians triaging patients on the phone and have a lot of concerns about administrative staff doing that. I think we can reassure them that NHS Pathways has been designed by clinicians, it's constantly reviewed and updated by clinicians. There's a very rigorous training process that the staff who operate the system go through. They spend many hours training, many hours being supervised. Calls, even after the training process, are constantly randomly reviewed and listened to, again by clinicians. There is a governance process around looking at NHS Pathways, about looking at any outcomes with which clinicians don't agree and about making changes. So I think from experience in the pilot area we can be fairly confident that it's a safe system.
Some patients obviously have special needs. They may be near the end of life, they've got special problems at a particular time. So how are they supported through 111?
111 deals with that in the same way that the out-of-hours services have dealt with special patient circumstances for years, in that the clinicians looking after the patient send the information into the service and that will be attached should the patient ring. It's one of the things that's been quite difficult during the implementation process to set up, because all the out-of-hours services and the ambulance service, for example, currently have different systems and different ways of doing it. What we're trying to do is use the information, the special notes we've already got, actually pull that together to make it work. And it's something that the clinical leads nationally are looking at around standardising the process really, for example, and the sort of information that's sent in.
And I think that would be very useful going forward.
And to add to that, we actually also use it, because it is a pilot, to learn from that. So if there's particular cases that are listened to from feedback from clinicians, we can then see perhaps whether the call taker needs further training, or, as Amanda said, if there's a pathways issue, we can see what part of the call was the issue and actually address that.
Of course, at the moment we have NHS Direct, which will be phased out. And how does 111 really differ from that, Jane?
I think the difference, the main difference, is the fact that there are no callbacks. Patients would be warm transferred through to out of hours or whatever service they've been referred to, or if they need nurse advice, they'll be warm transferred through, so there'll be no callbacks. They can dispatch an ambulance if actually it's deemed clinically required. So really, I would imagine that NHS Direct wanted to be 111 when it was first set up, really. However, they didn't have a local directory of services, you know, and the system wasn't set up that they would have warm transfers. And currently, NHS Direct calls back, and it can take up to an hour, where as a patient you may be fed up and take yourself down to A&E. So we're reducing that and hopefully giving patients a better experience.
We've got clinical commissioning groups coming on, and we've got clinicians involved in that. How do they need to get involved in the 111 programme over the coming months?
Well, in lots of ways. The CCGs are responsible for commissioning unscheduled care, and this is just part of that whole system, and it's absolutely vital that CCGs look at the whole system, because we really need to look in the North West at urgent care, about the costs and about the demand and about how we deal with patients and what the outcomes are, and 111's just part of that.
111's an enabler, really, and it's not a silver bullet. If we don't redesign the urgent care pathway below that, you will get what you always got. So it's about how 111 can enable that redesign of urgent care and be the single point of access for integrated 24/7 urgent care.
Well, we have a number of community services as alternatives to accident and emergency in our area. How do we ensure that 111 correctly directs patients to these services rather than defaults to an A&E?
And that's absolutely down to the local directory of services. So commissioners and our new clinical commissioning groups will actually prioritize where they want their patients to go. So you would have the services that could receive an urgent need. And I think that's something that people who are developing their directory of services will need to actually look at, because you could end up with a district nurse that had to be referred via a GP. So if you don't have services that are able to be directly referred to, then 111 doesn't have an option but to send it to the GP, the out of hours, or A&E. So I think it's about us reviewing what our local services that we have commissioned are and how we can actually access them.
Take us back to the urgent care pathway.
Absolutely. And at the same time, we're what's been developed nationally is it's called QDOS, and it's able to through using different scenarios, assess and test your directory of services before we go live. So that will be quite useful, because commissioners can actually test what outcomes the particular scenarios end up providing, and review them and actually change them if they need to before we go live.
I think Jane's district nurse example is a good example, because 111 is not just about a more cost-effective urgent care service, it's about getting patients to the right service without a lot of messing about and without being passed from service to service, which should actually improve the outcomes that we get.
And then from the Lancashire pilot perspectives, what's been the patient feedback so far?
We've had quite a lot of feedback in the pilot area, not just from patients but from clinicians as well, and it's been a mixture of positive feedback as well as some complaints. But to put it in perspective, well, we've had more than 100,000 calls so far. In April we had 26,000 calls and we had one complaint that related to the 111 service, so you can see that actually that number's very, very small. We had positive patient feedback. We've had a lot of feedback that is just commenting on the service. We've got a special email address, we've got phone numbers of local clinical leads. We've used clinicians a lot during the whole process, so at the moment we've used clinicians to input into the service specification. We're using clinicians on the evaluation panels for the bids for the rolled out 111 service. And what we really need now is, as the service goes live across the patch, we need clinicians to feedback on specific cases, whether they feel 111's done a good job, or whether they feel the disposition wasn't right, or whether they feel something different should have happened to the patient, because that's the information we need to evaluate the service.
Well, it certainly sounds as though our early experiences have been much more positive than we might have hoped for, and can look forward to the next few months and making this a part of our real new urgent care service. Thank you very much, Jane. Thank you very much, Amanda.
Thank you.
Thanks, Terry.